Hello, everyone. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. Basically, I want to go ahead and summarize for you like a daily recap. Very interesting last 24 hours. So I just finished a case, nice patient from California. 2 weeks and 2 days ago, she called me emergently stating that she had what was a ruptured silicone implant that was noted on an MRI that she recently had, and so there was an urgency for her. I did a what is a stat or an emergent phone consultation with her, and she basically, given her overall health, she basically got what was the medical clearance from her doctor that stated that she was optimized, ready, and clear for surgery. That means her heart was good, her labs were good, and when I talked to her, we were able to add her on as a third case for today. There was a sense of urgency on her end, and certainly on my end. No one should have to live with a ruptured implant. On the MRI, she had what was a intracapsular. That means within the capsular rupture of that implant. And so the goal was to contain it in the en bloc fashion, or 100% total capsulectomy in en bloc fashion. So none of the internal contents basically leaked out. And so please certainly go to my YouTube page or my Facebook page, and you will see firsthand exactly how the surgery was done. All contained, none of the silicone spilled into the chest. All of that implant, plus the capsular tissue, plus that inflamed tissue in the periphery of the capsule, was removed completely, definitively, sincerely, such that none of this spilled into the chest. And then the implants were given back to the patient, capsule sent to pathology, and cultures for aerobic, anaerobic, and fungal. I did what would be extensive skin contouring, which is the pseudolift, the Kahn Dakai pseudolift, where I cut out the excess skin. And this, with the internal sutures that I put that help medialize, pull the breast towards the midline and also superiorly, she ended up getting what is a pseudolift. No need for the drains. And I was very happy and content with how the whole dissection went. And so this is my very last case of the three cases that I did today. The other two patients, overall, the cases went very well, and I'm very happy and pleased. The other thing I want to mention, my very first phone consult this morning was to India, of all the places. So one of my prospective patients that I talked to is in New Delhi, India. So I talked to her. For most of my international phone calls, I do a call early in the morning, since it was later in the evening that today. And so she is only 36 years of age, and she had almost 40 of the symptoms of what is breast implant illness. She's been to lots of doctors, subspecialists, and all of them have yielded nothing. And she was referred to a psychiatrist for her stress, her anxiety. And this is what she, in her own words, said. Exactly verbatim, classic, what the many other patients have said, where they have gone to their primary care doctor and to the many other subspecialists, including the cardiologist. She had palpitations, the allergy immunologist, the endocrinologist, the rheumatologist, and all of the workup yielded essentially nothing. And this is where they told her that she has essentially a clean bill of health. She knows better that her symptoms are real and that they are not in her head, and that she has a whole life ahead of her at age 36. And she was able to find me on the internet. She was able to relate to the many patients. She even saw the many, many videos, and then she sought a phone consultation out. I did ask her, interestingly, what percent chance she thought that she had bet what is breast implant illness, and she said 120%, close quotes. And I said 1,000,000%, because this is exactly what the constellation of signs and symptoms that she was exhibiting. Now, only when she undergoes and goes through the entire implant plus capsule plus all that inflamed tissue removal, and that all of that badness is removed post-op, we will see like 90% of the patients that have only improved and benefited from their explant. So the bottom line here is that you need to educate yourself. You need to get that confidence, that trust factor in your surgeon. Your surgeon should be not promoting sales of products or trying to capitalize on detox. I just want to mention that detox, the only and the best detox is that the surgeon removes the entire implant capsule and all of that inflamed tissue completely, sincerely, definitively, be it above the muscle or below, and that the patient is eating healthy. Patients eating fruits and vegetables, non-processed food, that the labs are being checked, for example, vitamin B12. So this very nice patient from India, she basically, her diet was very compromised, and so she was not eating much. So I told her she needs to get the Ensure, she needs to go ahead and get some supplement drinks, just like the elderly or the patients who have had other surgeries done, so that she absolutely makes sure that she has the appropriate vitamins A, D, E, K, and all the other nutrients, zinc and magnesium and everything else that can indeed be taken by those supplements. But there is really no need to take anything that would be like vitamin C. If you take an orange per day, that's good enough. You do not have to take a pill if you can certainly take it by mouth, i.e., in a natural way. And so you want to be optimized, and the only detox is where the surgeon himself or herself is able to remove the entirety of the implant capsule and that toxic burden, which is that implant and that inflamed tissue around into which that silica has leached into. So I want to also go ahead and mention that, taking charcoal, for example, that's meant for the emergency room doctor to give it to the patient who ingested like 20, 30 aspirins to commit suicide, or accidentally, for example, if a kid took it. There is no leaching agent that you're going to take that's going to basically pull together the silicone. If that was the case, the patients would not need any surgery, and that all of the silicone would essentially bind to that. So there is no chemical out there, no product out there. If your vitamin B12 level is low, you don't have to get it in your IV. Just take it and supplement it. And just like you measure gas in your car and it's low and you have to add it, you have to measure the vitamin B12 that's low, then you add it. If your vitamin D level is low, then you add it. Magnesium is low, you add it, and adding the right amount. There are patients, unfortunately, who have had liver problems because they took a lot of supplements, and God only knows where the supplements are made in. Maybe China, South America, maybe in someone's garage or backyard. So you have to know what you're buying. No one truly regulates these chemicals, and so it is very dangerous to take them. So one of my patients that I talked to a couple of days ago, she actually had liver problems, and so she was going to get a liver biopsy. And the first thing that her hepatologist said was, stop the supplements because there is a lot of unknown factor. One of my own very patients, she was getting a pre-op clearance and her potassium came back at 5.5. And the next thing you know, the workup shows that it was one of those supplements that she was taking that was causing her potassium to go high. Now, I want to go ahead and discuss one other very important point that one of my second patients for today brought up. And she said to me, I saw some of the pictures on your Facebook, on your web page and on your Facebook page, and they are a little bit concerning. Now, let me go ahead and dive into this a little bit more. Now, another patient showed me when I was in California, another surgeon's website, and said, look, these are 10 perfect results. And this is what are these results, and look at your website. I said, I have almost 500,000 to 700,000 pictures with me. I can go and pick the top 10 ones, the top 20 ones, and I can post them, and it will lure and trick you into seeing and believing that these are the results that I have. So first and foremost, do not believe that that's going to be you number 11. Now, no one can guarantee that you're going to be like number 10, number 11, or number 8. This is all kind of an illusion. When I made my website, www, that basically runs my web page, that company told me they have a pool of model patients. And those patients, they can post on my website to show, and it would state in very fine print, not the surgeon's own work. And so this is where you want to be very careful. One of the patients that I talked to, she stated that she saw one patient's pictures on a surgeon's website, And on another surgeon's website, she saw the same patient's picture. Now, how wrong, and if you ask me, unethical that you're using someone else's work to promote your practice. Now, in my practice, I only show whatever is my work. Most of the work that you will see is 3 weeks, 6 weeks, because most of my patients, 80, 90% of them travel. Now, if you have a patient that has a capsular contracture on one side, grade 4, and the other side is grade 2, you can only imagine 3, 4, 6 weeks out, the right result is going to be different. If one implant, I have a patient from Spain, her MRI shows that the right implant is above the muscle, the left implant is below the muscle. She's absolutely going to have a different result because her previous surgeon, quote, messed up, lack of a better word. There's another patient where she had radiation on one side and no radiation on the other. So you can see there's going to be a difference certainly as well. Another patient had surgery done by a non-board certified surgeon. And that in itself tells me, and this is what I see, that the problems that were created by the previous surgery are going to be a lot more and different than what I'm going to have to deal with from another patient. Another patient had 5, 6, 7 surgeries. The surgeon went once through the nipple areola, the second one through the armpit, the third one through the inframammary crease incision. So you can imagine she has a lot of scarring. One patient had implants above the muscle, the other one below. And so I want each and every one of you to understand there is pure transparency on my website so that you're not tricked or deceived into thinking that these are the best results, because the human mind and psyche gets lured into the obvious. Oh, I want this. I want to see this. Whenever they sell a car, they make it shiny and nice and clean. Again, gives you the illusion that it is clean from the outside and in. And the bottom line here is, this is real medicine. This is real surgery. I see the post of one of my patients that I operated on. You will see she had 550 cc implant. And if you look at her chest width is but 7, 8 centimeters. So the surgeon who put the implant in her, or maybe it was the patient's choice, was way too big. And remember, you cannot go medially, you cannot go towards the midline, you cannot go towards the side, you cannot go up, you have to only go down, and the inframammary crease ligament gets violated. Now, if you have a really large implant that's sitting at the bottom and the patient's breast tissue native is much further up, you can only imagine her incision's only going to be lower, because imagine someone has 800 cc implant and she is 95 pounds and 5 feet 2. You can only imagine it's going to go much further down laterally, medially, and superiorly. And if the explant is done, her incision is going to be relatively lower because her surgeon changed the old crease that was much higher up to a lower crease. And if I have to make the cut at the bottom, that incision is only going to be at the bottom because her surgeon and the patient's choice of the large implant, if that is what the patient wanted, now has changed the chest for the worse, if you will. One patient may have a rupture on one side and no rupture on the other. One patient may have fluid and whatnot else, as you saw on the Facebook Live from last Thursday. You will see that the left breast implant had severe contracture with fluid and a mass within the implant, whereas the right side was within normal limits. The left side was putting out discharge. And so the bottom line here is a surgery done by a board-certified plastic surgeon, a surgery done above the muscle is very different than when done below. So there's so many differences that you're going to see. So you have to be very careful and you have to be very smart. You have to see what and how the patient that you're seeing and analyzing, what your surgeon did. You will see, unfortunately, I want each and every single surgeon to post all of their results from the many surgeries they're done, so you can see firsthand the scars are on the nipple areola up and down, if your surgeon is choosing to do so, what the long-term sequela of that is. And this is where the complete transparency must come into play. So in my practice, as I go in, so this one patient who very genuinely and very appropriately asked me this question, she had, and very interestingly, the right breast implant was higher up, the inframammary crease was much higher up almost by half an inch to three-fourths of an inch on the right side. The width of the breast on the right was much wider than on the left, where the inframammary crease was lower and the breast tissue was much narrower. So what I did was, so this is the second case I did today, no HIPAA violation. I put a dot at the nipple on the right, and I measured exactly 5.5 centimeters to the right to where the incision was made. And then on the left, 5.5 centimeters exactly from the nipple all the way down. I do not touch the breast tissue. I do not want any cuts in and around the nipple areola. If you ask me, that's like a major violation in my practice. I don't want any pins and needle sensation around the nipple. I don't want any unsightly hypopigmented, hypertrophic, or keloid type scars. I don't want any cuts anywhere else except for a cut right in the crease at the bottom. That is the only cut, if you ask me, where you can dissect parallel to the rib, and in the 4 hours that I take plus minus, such that I'm able to completely, definitively, sincerely remove the entire implant, plus the capsule, plus all inflamed tissue, genuinely, respectfully, honestly, with integrity and professionalism, because I know the patient's well-being post-op depends on me doing the job where there should be absolutely no capsule left behind, and all of the capsular tissue is removed, and all inflamed tissue is removed, and the implant is removed in what is the end block fashion, or 100% total capsulectomy. And in my practice, what that means is the fascia of the intercostal muscle is removed. The fascia of the pectoralis minor is removed, which is the layer of fascia right on top of the pectoralis minor, onto which the implant is sitting if the implant is below the muscle. The fascia of the serratus anterior is removed. The periosteum and perichondrium is removed. That essentially ensures that the entirety of the capsule is definitively removed. If you can imagine, you have a water balloon, if you have a saline implant, or you have a balloon that is full of gel, if you will, sitting on a uh, on a on, like, say for example, a seat. In order to completely remove that water balloon without breaking that balloon, you have to get that leather, if you will, off of the seat as well. And that is basically what ensures complete removal of that water balloon, if you will, off of that seat. In a similar fashion, in order to completely remove the entire implant capsule, all inflamed tissue, along with that capsular tissue that's tightly adherent to the rib, the fascia of this respective muscle, serratus anterior, pectoralis minor, intercostal muscle, plus perichondrium and periosteum, has to be removed in order to ensure complete removal of the capsule. And that is what needs to be and must be shown by your surgeon. So there's a lot that goes into showing definitively that your surgeon is doing the right surgery. Yesterday, I talked to another patient who said that another surgeon's office was saying, I don't repair the muscle. I will tell you, their muscle absolutely must be repaired. No surgeon should speak for another surgeon. They should discuss exactly what they do to their patients, not what other surgeons are doing, and not mention my practice by name, and which is unprofessional, unethical, and if you ask me, absolutely wrong. I want every surgeon needs to show high definition pictures and videos. If a surgeon is doing fat grafting and a supposed end block and a supposed lift in 2.5 hours, I have a major problem with that. I want to see the whole procedure, because I want to see how the surgeon is doing that surgery in the manner that he or she is describing. And as you will see, there will be no mention or videos showing that. And this is where the transparency comes into play. If you go to 10 different plastic surgeons, without a doubt, you're going to get 10 different ways as to how the surgeon is going to be doing their practice. And within their practice, you're going to see variations. We see a lot of surgeons posting the easy cases and showing that they're doing the end blocks, but when the tough cases come and the silicone spills into the chest, unfortunately, in their practices, the drains become mandatory. I will tell you, the drains are absolutely not required, and I'll end with this, because all of the bad tissue is removed sincerely, definitively, wholeheartedly. There is no silicone that spills into the chest. No capsule is left behind. The blood loss is less than 5 cc's. There is nothing that's going to stimulate seroma formation. And because all of the badness is removed, the need for the drain is not there. And just like with any plastic surgery, you have to have compression devices, be it the bra and binder, just like after a tummy tuck, thigh lift, gynecomastia, and in this case, explant, the bra and binder is an integral part of the recovery. So if your surgeon is telling you you can go to the gym in 2 weeks, I will beg to differ, because you would not have had the right surgery then. If your surgeon is saying that you do not need garments, I will tell you that is contrary to the plastic surgery 101 principles. Look at Marina Garments. They build their entire garments around basically providing post-op compression care for all of these surgical procedures. So if a tummy tuck is done and the patient is not wearing pressure garments, if you ask me, that is considered malpractice, because you want to be able to hold that flap of tissue in, just like with explant surgery in, so that you get and one gets the optimal recovery. Now, I want you to please go ahead and ask questions. I hope to do one every single day, so I can address any of these issues. On the next time I talk, I'm going to talk about the soda lift. We're planning on having our anesthesiologist, Dr. Alex Amar. He will be as a guest, and so he can answer any of your questions in the next forthcoming weeks. We're going to have plenty of patients of mine, so we can hear directly from them as to what their thought processes were. We appreciate the many patients who come forth and share their journey with the many others. Remember, this is a movement by the ladies for the ladies. If this one patient who came to me from California listened to the top 100 plastic surgeons in the country, she would have inevitably ended up getting another set of implants, such that 10 years later, when she would be 75 plus minus, she would have had to live with the unknown of having what are silicone or saline implants. So do your homework, do your due diligence. Please know what you're signing up for. Listen to what the FDA is saying, what the manufacturers are saying, and listen to, ultimately, most importantly, what the many patients are saying in regards to their experiences. I will end with this. We're planning on having a clinic in California, again, the first week of November. This is when I plan on having my surgeries. Tentatively, we're looking at the very first part of November. So if you're interested in seeing me in person in Northridge, California, or having your surgery soon thereafter, please, by all means, reach my office for a phone consultation. Do your homework. Talk to the surgeon directly. Talk to and discuss with your surgeon directly. No need to talk to the receptionist or the physician assistant or the nurse practitioner, because they're not going to be doing your surgery. You need to have the bond with your surgeon. You need to have that confidence with your surgeon. You need to have that unshakable belief that your surgeon is going to do the right surgery, and that you should have that peace of mind that you entrust your health in your surgeon, because he's only genuinely interested in getting you back and healthy. This is Dr. Khan, Executive Plastic Surgery.